Pancreatitis in cats is a relatively common disorder that can cause significant illness and, in some cases, death. The clinical signs of pancreatitis can be vague and nonspecific, making it difficult to diagnose based on clinical presentation alone. Advances in pancreatic serology and imaging have improved the ante-mortem diagnosis of pancreatitis in cats. A polyclonal sandwich radioimmunoassay for feline pancreatic lipase immunoreactivity (FPLI) was developed, validated, and performed at the Gastrointestinal Laboratory, Texas A&M University. The assay was shown to be both sensitive in cats with moderate to severe pancreatitis and specific in healthy cats. However, a lower sensitivity was noted in cats with mild pancreatitis. This assay has been replaced by a commercially available assay, Spec FPL test, IDEX Laboratories Incorporated, for the measurement of serum FPLI concentration. The Spec FPL test is species-specific and utilizes monoclonal antibodies to bind a single specific binding site. Transabdominal pancreatic ultrasonographic evaluation has been shown to be a moderately sensitive test for pancreatitis in cats. However, variable specificity has been reported. Unlike serology, ultrasonography is operator, equipment, and patient compliance dependent. The benefits of ultrasonography include the detection of concurrent non-pancreatic disorders, screening for underlying causes of pancreatitis, and ultrasound-guided fine needle aspiration (FNA). Cytology of the pancreas and peripancreatic fluid accumulations. This study aimed to establish the reference interval for the Spec FPL test in apparently healthy cats and to determine the sensitivity and specificity of the Spec FPL test in a large group of ill cats with and without pancreatitis. Study design. This was a prospective, cross-sectional, non-randomized study. A total of 182 cats were enrolled in the study, including 141 cats with clinical signs consistent with pancreatitis and 41 healthy cats. The healthy cats had no history of gastrointestinal disease and were not receiving any medications other than heartworm, tick, or flea preventatives. All cats underwent the same diagnostic evaluation, including a complete medical history, physical examination, complete blood count (CBC) serum biochemical profile, urinalysis, measurement of serum FPLI concentration, and pancreatic ultrasonography. Pancreatic FNA or biopsy was performed when indicated for the clinical cats to obtain samples for cytologic or histologic examination, but no pancreatic procedures were performed in the healthy cats. Additional diagnostic testing was performed as needed for clinical cats. The Spec FPL test is a sandwich enzyme-linked immunosorbent assay, ELISA, utilizing a mouse monoclonal capture antibody coated on a 96-well microtiter plate, and a second enzyme-labeled mouse monoclonal detection antibody. The antibodies were developed using native feline pancreatic lipase purified from feline pancreata. Calibrators containing recombinant feline pancreatic lipase are used to construct a dose-response curve for each assay to determine the concentration of pancreatic lipase in feline serum samples. The Spec FPL test requires 25 microl of serum, which is run in duplicate. Transabdominal ultrasonography was performed using the same ultrasound system. Technis MP 8.5 MHz convex array and 13 MHz linear array transducers. By a Sound SAO Incorporated. By one of two board-certified veterinary radiologists. Multiple still images of the pancreas were acquired from each cat, along with any images of non-pancreatic abnormalities. A single radiologist reviewed all images in a masked fashion following completion of the study. The criteria considered were visualization of the majority of the pancreas, pancreatic border characteristics, echogenicity of the pancreas relative to the liver, pancreatic duct size, peripancreatic fluid accumulation, the presence of pancreatic nodules or cysts, and the presence of enlarged peripancreatic lymph nodes. A grading scale for findings on transabdominal pancreatic ultrasonography was designed a priori. The pancreas was considered to be enlarged if the left lobe was thicker than 9.5 mm, the body greater than 8.5 mm, or the right lobe greater than 6 mm. The degree of enlargement was graded as mild, moderate, or severe. The pancreatic duct was considered enlarged if it measured greater than 2.5 mm in diameter. Cytologic samples were obtained using an aspiration, freehand technique by a board-certified radiologist. Samples were obtained from a sonographically abnormal appearing portion of the pancreas. Cytologic evaluation was performed by a single board-certified clinical pathologist, who had access to the clinical history, but was masked to the PLI concentration. Surgical pancreatic biopsy samples were obtained from anesthetized cats using a ligature technique or laparoscopic biopsy. Histologic evaluation was performed by a single board-certified pathologist masked to the FPLI results. Histopathology was also performed on the entire pancreas from cats that died or were euthanized during the study. The pancreata were fixed in 10% neutral buffered formalin and sectioned every 1 cm. The sections were routinely processed and stained with hematoxylin and eosin. All postmortem pancreatic histopathology samples were reviewed and scored by a single, masked, board-certified pathologist using a modified semi-quantitative histopathology grading scheme. A 6-category classification scheme was developed a priori to classify each cat's likelihood of having pancreatitis. Definitely pancreatitis, probably pancreatitis, possibly pancreatitis, possibly not pancreatitis, probably not pancreatitis, and definitely not pancreatitis. The ACVIM diplomates supervising the clinical care of each cat presented each case to 2 masked ACVIM diplomates, who reviewed all information except the FPLI results. Histologic evidence of pancreatitis or lack thereof was weighted most heavily. A cat was not classified as definitely pancreatitis, unless there was histopathologic evidence of acute or chronic inflammation and/or necrosis in at least one section of the pancreas. The absence of these lesions was evidence that a cat did not have pancreatitis, classified as definitely not pancreatitis. Although a cat could also be classified as definitely not pancreatitis if there were normal pancreatic ultrasonography findings, with an absence of supportive clinical evidence. Even if histopathology of the pancreas was not available, convincing ultrasonographic evidence of pancreatitis, along with supportive clinical evidence, was required to classify a cat as probably pancreatitis. Cats with weak or no evidence of pancreatitis could be classified as possibly pancreatitis, possibly not pancreatitis, or probably not pancreatitis based on the overall clinical assessment. Clinical signs considered consistent with pancreatitis included lethargy, inappetence or anorexia, apparent abdominal pain, weight loss, dehydration, hypothermia or fever, jaundice, vomiting, and/or diarrhea. Laboratory findings consistent with pancreatitis included leukocytosis or leukopenia, increased liver enzyme activity, hyperbilirubinemia, hypoalbuminemia, hypocalcemia, hypokalemia, prerenal azotemia, hypercholesterolemia, and/or hyperglycemia or hypoglycemia. Statistical analysis was performed using commercially available software, SAS, version 9.2, SAS Institute Incorporated. Descriptive data for continuous variables were reported as means, medians, standard deviations, interquartile ranges, and ranges. Descriptive data for categorical variables were reported as frequencies and counts. A p-value of less than 0.05 was considered significant for all hypothesis tests. Non-parametric statistical methods were used because the Spec FPL test measurements of PLE concentrations were not normally distributed. Results say total of 182 cats were enrolled in the study, 141 clinical cats and 41 healthy cats. Of the 141 clinical cats, 5 underwent ultrasound-guided pancreatic FNA for cytologic examination and 17 underwent pancreatic biopsy for histologic examination. Procedures for biopsy included a ligature technique, N=2, or laparoscopic biopsy using a clamshell biopsy device 1. Additionally, 14 cats had a post-mortem histologic examination performed on the entire pancreas. Of the 34 cats with pancreatitis, 12%, had pancreatic FNA cytology performed, and 26%, had pancreatic histologic examination performed. A cellular sample was obtained via FNA cytology in 3 of 4 cases. In the other case, the sample was inconclusive due to an insufficient number of tissue cells. Acute inflammation was reported in 2 cats, and hyperplasia of pancreatic epithelial cells was reported in 1 cat. 1 cat had carcinoma with acute inflammation. All 9 cats that were classified as definitely pancreatitis by histopathology had evidence of acute inflammation and necrosis in at least one section of the pancreas. Other lesions present included chronic inflammation, N=9 cats, nodules 8 cysts 8 fibrosis 6 atrophy 3 and edema 2. Pancreatic islet amyloid and pancreatic adenocarcinoma were detected in 4 and 2 cats, respectively. 1 cat with pancreatic adenocarcinoma also had evidence of adenocarcinoma in intestinal histopathology samples. Similar clinical signs were noted in the 3 cats diagnosed with pancreatic carcinoma. The Spec FPL test results were PLE concentrations of 5.4, 25, and 36 microgal. Pancreatic ultrasonographic abnormalities included pancreatomegaly, N=3 cats, grade 2 to 3, with hypoechoic pancreatic echogenicity, hyperechoic peripancreatic echogenicity, and a mild to moderate, irregular pancreatic capsular margin. Of the 48 cats with indeterminate pancreatitis, 2 had pancreatic FNA cytology, which revealed well-differentiated pancreatic epithelial cells with no cytologic abnormalities in 1 cat. Surgical pancreatic biopsy histopathology in the 2nd cat revealed nodular hyperplasia. Intestinal and hepatic histopathology in this cat revealed mild to moderate lymphocytic enteritis of the duodenum and jejunum, minimal biliary hyperplasia, and multifocal lymphocytic portal hepatitis. Of the 59 clinical cats without pancreatitis, 7 had pancreatic biopsies performed. No pancreatic cytology was performed in this group. All pancreatic biopsy samples were diagnostic. Histopathology of the 2 cats with premortem biopsies revealed pancreatic nodular hyperplasia. Of the 5 cats with post-mortem histopathology, none had acute inflammation or necrosis present in any section. Other lesions present included chronic inflammation, N=5 cats, nodules 5 pancreatic islet amyloid 4 fibrosis 3 cysts 3 edema 1 and atrophy 1. Mild hepatic lipidosis was found in 2 of 2 cats with liver histopathology available. Low-grade small intestinal lymphoma was detected in 1 cat with intestinal histopathology. Similar to previous studies, lethargy, 91% of the 34 cats in the pancreatitis group, anorexia, 82%, and weight loss, 74%, were commonly noted clinical signs. No differences were noted between cats in the pancreatitis and not pancreatitis groups. Abdominal pain, 68%, and dehydration, 50%, were noted on physical examination in cats in the pancreatitis group. Table 1 shows the results of key clinical signs, physical examination findings, and concurrent diseases diagnosed in healthy cats, N=41, and ill cats, N equals 141 evaluated for pancreatitis, with clinical cats grouped on the basis of a clinical diagnosis criteria classification scheme into the pancreatitis group, intermediate pancreatitis group, or not pancreatitis group. Table 2 shows the median and range of selected CBC, serum biochemistry, urinalysis, and FPLE results for the 41 healthy cats and the 137 clinical cats. Multiple significant but weak Spearman rank correlations were noted for serum FPLE concentration and the following variables: creatinine, blood urea nitrogen monospartate aminotransferase, AST gamma glutamyltransferase, GGT, albumin, glucose, calcium, total carbon dioxide, white blood cell WBC count, hematocrit, and urine-specific gravity. Significant differences were noted for serum FPLE concentrations between healthy cats, cats with pancreatitis, cats with indeterminate pancreatitis, and cats without pancreatitis. There was a clear increasing trend in serum FPLE concentrations as the disease grade progressed from healthy to definitely pancreatitis. Table 3 shows the transabdominal pancreatic ultrasonography scores for pancreatic size, contour, duct size, the presence of cysts or nodules, peripancreatic fluid accumulation, and peripancreatic enlarged lymph nodes for the healthy cats and clinical cats. Abdominal ultrasonography scores for pancreatic size, pancreatomegaly, and contour, but not for fluid accumulations, nodules, peripancreatic fluid accumulation, or enlarged peripancreatic lymph nodes were different between the pancreatitis and not pancreatitis groups, but not between the indeterminate pancreatitis and not pancreatitis groups. The pancreas parenchyma and peripancreas mesentery were isoechoic in all healthy cats and abnormal, hypoechoic, hyperechoic, and mixed hypoechoic and hyperechoic. For cats in the pancreatitis, 26, 0, and 4, 0 and 26, respectively, not pancreatitis, 5, 3, and 1, 0 and 3, respectively, and indeterminate, 18, 1, and 4, 0 and 12, respectively, groups, the distribution of ultrasonographic lesions was none. No lesions were noted. In all the healthy cats and abnormal, focal, regional, multifocal, and diffuse for cats in the pancreatitis, 10, 14, 3, and 3, respectively, not pancreatitis, 12, 2, 0, and 0, respectively, and indeterminate groups, 16, 11, 2, and 5, respectively. The most common ultrasonographic pancreatic abnormalities detected in the pancreatitis group of cats were a hypoechoic pancreas, 76%, hyperechoic peripancreas mesentery, 76%, pancreatomegaly, 74%, 44% moderate, with an irregular contour, 82%, 46% mild, and regionally distributed, 47%. Numerous concurrent disorders were noted in the clinical cats, including acute and chronic kidney disease, hepatic lipidosis, diabetes mellitus or diabetic ketoacidosis, hyperthyroidism, probable or confirmed cancer, and inflammatory bowel disease. Figure 1 shows the results of the receiver-operator characteristics curve to establish the cutoff value for the Spec FPL test that maximizes both sensitivity and specificity. Using a serum FPLE concentration of greater than or equal to 5.4 microgal as the diagnostic cutoff, the sensitivity and specificity, and their respective 95% confidence intervals CIs of the Spec FPL test were 79.4%, 63.2% to 89.7%, and 79.7%, 67.7% to 88.0%, respectively. The positive and negative likelihood ratios were 3.9 and 0.3, respectively. When considering all 182 cats in the study and grouping possibly pancreatitis cats with the pancreatitis group and possibly not pancreatitis cats with the not pancreatitis group, the sensitivity and specificity, and their respective 95% CIs, were 65.1%, 52.8% to 75.7%, and 82.1%, 72.1% to 89.0%, respectively. The positive and negative likelihood ratios were 3.6 and 0.4, respectively. The positive and negative predictive values were 69% and 87%, respectively. Figure 2 is a scatter plot with the results of the Spec FPL test on the x-axis and the results of the FPLE radioimmunoassay on the y-axis. The figure shows a high correlation between the Spec FPL test and the FPLE radioimmunoassay. Table 4 shows the results of the Spec FPL test precision for measuring FPLE concentration in 786 stored sera with known FPLE concentrations. Precision was determined by assaying each of 7 feline serum samples with doses spanning the assay range in 8 replicates. The table displays the average Spec FPL dose, total precision, intra-assay precision, inter-assay precision, total coefficient of variation, intra-assay coefficient of variation, and inter-assay coefficient of variation. Discussion. The reference interval for serum FPLE concentration as measured by the Spec FPL test was determined to be 0.7 to 3.5 microgal. This reference interval was based on measurements in a group of healthy cats with clinically normal results on routine laboratory testing and abdominal ultrasonography. The diagnostic cutoff for serum FPLE concentration that maximized the test sensitivity and specificity was determined to be greater than or equal to 5.4 microgal. Using this cutoff, the Spec FPL assay was 79.4% sensitive and 79.7% specific. If the serum FPLE concentration was within the reference interval in cats with clinical signs of pancreatitis, the sensitivity of the Spec FPL concentration for excluding pancreatitis increased to 85.3%. but the specificity decreased to 64.4%. This study had several limitations, including the age difference between the healthy control cats and the clinical cats, and the reliance on a clinical classification scheme for the diagnosis of pancreatitis rather than histopathology in all cases. The mean age of the clinical cats was 11 years, while the mean age of the healthy cats was 5 years. The authors acknowledged that the rigid selection criteria for the healthy control cats, which required no current or historical gastrointestinal clinical signs, potentially excluded some cats that could have been appropriate for the healthy control population. Although histopathology is considered the gold standard for diagnosing many disorders, it has some limitations, particularly regarding the diagnosis of pancreatitis. Pancreatitis can be multifocal, and areas of inflammation could be missed without serial sections of the entire pancreas, which is not possible in a clinical setting. Conclusions. The high sensitivity of the Spec FPL test suggests that it is an appropriate screening test for cats with clinical signs compatible with pancreatitis. The high specificity of the test suggests that it is an appropriate test to diagnose pancreatitis when results are integrated with other clinical findings. The authors of this study recommend additional clinical studies to confirm the results of the study, ideally including pancreatic histopathology. From Vet NeuroJar. Keep those minds inspired, hearts light, and tails wagging.